Hello, friends. Welcome to the yet another fascinating panel discussion at the second edition of Elets Hospital Infrastructure Summit. This panel discussion is on the year ahead design trends. So let's welcome our eminent panelists. Please join your hands together for Dr. Chandrika Kambam. She is Director for Clinical Services at Healthcare Global Enterprises Limited. Also, please welcome Mr. Namit Soni, Director and CEO, Soni Hospitals. I also have the pleasure to welcome Dr. Saurabh Lall, who is Head of Hospital Operations at Max Healthcare. Dr. Lal will also be moderating this panel discussion. Next is Mr. Shamit Manchanda, Chief Healthcare Architect at Manchanda Associates. Welcome, Mr. Shamit. Next is Mr. Dibyajyoti Dr. Roy, owner at RJB Architects. Welcome, Mr. Dr. Roy. I would now like to go across to Dr. Lal for moderating this panel discussion. Dr. Lal, over to you.
Thank you. Thank you so much for the kind words and the warm welcome. So, I will quickly and directly jump on to the topic, which today is the year ahead design trends. So, essentially, design is, by definition, the process and skill of planning how something should be made and how it will function in the best possible way or the most optimized way. Also, a second perspective to design is design thinking. So, by definition, it is the term that we use to represent a set of cognitive, strategic, and practical processes in which design concepts are developed. In today's time, I think, especially in healthcare, the concept of design and design thinking is absolutely essential because we have kind of hit a very sharp curve in the industry, and we have reached a stage where survival of the fittest is the only way ahead. And when I say survival, I would request that to be read as innovation rather than survival. So, innovation and out of the box ideas are the key to future healthcare, and out of the box ideas are not executable till the time they are scalable, sustainable, and replicable. So, with that thought, I think I will move on to Mr. Shamit Manchanda from Manchanda Associates, and I think we can set the tone to the discussion where he will give us an architectural perspective. So, Mr. Manchanda, could you please share the trends in hospitals? You design a lot of hospitals, so what do you think are the newer trends in hospital design that are things that have evolved over the years, and more importantly the last 2 years, and how is design of hospitals different today than it was before the pandemic and the associated factors? Over to you, Mr. Shamit.
Thank you, Dr. Saurabh, for introducing me and setting the tone for the discussion, and reminding all of us that design thinking is a very crucial part of the whole process. To get back to the topic, design trends, something that some things that we are going to be seeing more and more over the next few years is that a lot of organizations today are going in for accreditation, be it NABH or JCI. So they have, initially it was mostly private. Now even the government organizations, government hospitals are going in for NABH accreditation, which basically helps in ensuring that it improves patient safety and quality of healthcare provided to the patients. And with the advent of medical tourism also picking up, which is an important driver, many private hospitals are aspiring to achieve JCI accreditation. So accreditation is something that is going to be a thing that we're going to see in the coming years ahead. And how it affects from the architectural perspective, most of the NABH and JCI norms are based on your standard operating procedures, SOPs. But there are a few things that have to be incorporated in terms of architectural planning, and if not done at the design stage itself, it becomes very difficult to achieve. So uh, one, now when you are designing a hospital, you have to make sure that there will not be any problems when you go in for any kind of accreditation. Another thing that we are seeing now is the more and more advent of hub and spoke model for hospitals. The push for new hospitals is going to be in tier 2 and tier 3 cities where these facilities have been having. So many corporate hospital chains are moving into these smaller towns either by constructing new hospitals on their own or mostly by taking over existing hospitals, adopting a hub and spoke model. There is also a shift towards ambulatory and daycare procedures. So, where with an increasing focus on wellness and short stays for critical procedures, ambulatory care centers are coming into more prominence. So, that is another thing that we will be seeing lesser of inpatient stays and more of these ambulatory and daycare surgeries, etc., and procedures happening. New technologies are being adopted, so we have to design according to them. E-connectivity is being built into almost everything from medical equipment to patient rooms to electronic medical records. Even the Prime Minister announced day before yesterday of having a system of digital records, health records for everybody. Use of telemedicine, as we have seen over the years in terms of after the COVID happened, it has increased manyfold. And on the building infrastructure side, more and more hospitals are adopting what we call as the IBMS system, which is the Intelligent Building Management Systems, to bring in more optimal utilization and increasing efficiency. For large corporate hospitals, we are also seeing the use of hybrid and bar notice, robotic surgeries coming in, use of pneumatic tube systems, pneumatic waste collection systems. So these are things in terms from an architectural perspective we have to build into the systems which were not there earlier. Uh, the trend has been towards more and more owners, corporate offices, houses, as well as other smaller private bodies are going in for green and sustainable rating systems, so that the buildings are more energy efficient, use less, use more light, natural light, use of wastewater recycling, energy recycling, and use of renewable sources of energy. So that is another very important thing is emphasis on patient focused hospitals is increasing. The patient till recently was just an object on the scene than the focus of design, and sensitivity to people's feelings and their needs is entered the vocabulary of facility planning and design. So that is another thing that we are seeing more. And in terms of COVID, what we are seeing is the emphasis on infection control is going to go up. Infection control is going to be the major driver for hospital planning post this pandemic. Right from the entry point where patients and relatives enter, we will need to create triaging areas to screen patients. Increased physical distancing norms will mean larger waiting spaces, which have to be very well ventilated. Corridors could be unidirectional and much wider than we had today. Introduction of donning and doffing areas, which was not there earlier. Bed to bed distances need to be rethought and have to be increased. Uh, Earlier, though in the private sector, we would give oxygen supply and medical gas pipeline systems on all beds, but in the government hospitals, we would put it only on maybe out of 6 beds, only 1 or 2 beds. Now that thing will have to be rethought, and maybe each bed will now need to have an oxygen supply, and also to design the system to cater to the surge demand. Earlier, maybe just only 10-15% of the beds required oxygen, and in the last second wave, we saw that almost 100% of the beds required oxygen supply. Uh, the possibility to switch from positive pressure to negative pressure rooms, use of technology in terms of to kill and trap the infection by using there are what are we call this the UVGI lamps, the ultraviolet germ irradiation lamps in the air conditioning systems. more use of antimicrobial touch surfaces like copper and antifungal paints, increased use of sensor operated doors. So these are certain things that I see that will be coming in over the years in terms of design changes and trends that are going to be happening. Thank you.
Thank you so much, Mr. Manchanda. That was an insightful architect's perspective about the change. I think as I always believe and tell people, it's usually the complexities that pertain to the life cycle of patients through administrative processes of a hospital that lead to inconvenience and dissatisfaction. And many a times people are unable to understand what the next step is, because there was a time in healthcare when the moment there used to be a problem in the hospital in terms of processes, and we are talking more on the patient satisfaction front, on the infra satisfaction front, the obvious answer would be to add a couple of people as part of the team and try and scale it up. But over the years we've realized that that is not the only answer, or rather that is not the right answer. So what do we do apart from that? So that the answer is that these days healthcare is now moving in a space which is absolutely driven by technology, and technology is the new normal. The best and the top of the head idea that I have in my mind is the replication of processes from other industries. So, I mean, something that we've also been trying to contemplate at our hospitals is, for example, replicating the infra development of hotels and airlines, airports, etc., at the hospital to ensure that the processes are aligned. So on that front, let me kind of bring in Dr. Chandrika Kadam, who's the Director Clinical Services for HCG Group of Hospitals. So, Dr. Chandrika, I think you've been doing a lot of work on that front, and we would like to know what do you think and what is your perspective of the role of technology in design, and how technology can make design more pronounced for addressing, extraordinary situations like pandemics and epidemics. So, Dr. Chandrika, can we hear from you on that, please?
Yes, good afternoon, everyone, and thank you, Elet, for giving me this opportunity to be on this panel with esteemed panel members. Uh, as Saurabh said, and also as Dr. Manchandani said, that the design of the hospitals are changing, and definitely with that, I think the last 1 or 2 years. We have extensively heard about the use of technology in healthcare and how the technology was leveraged, especially during the pandemic. But let us step back a little, like how the previous speaker explained, that the designs of the hospitals are changing. Similarly, we also need to give focus on the infrastructure when we are designing the hospital about to make it efficient for technology to work. So, just talking about adopting technology at the forefront is not going to happen if the infrastructure is not ready. The hardware is not ready, the lines are not put in place, the Wi-Fi connectivity is not there, so on and so forth. So if these infrastructure issues are not in place, forget about adopting technology, because it is going to make the life of the doctors and nurses more miserable, and it is not going to help us in any way to make it more convenient for them. So it is very important that we take into cognizant this necessity that has come because of the pandemic, get our hospitals hardware ready, the IT infrastructure ready, put in the necessary internet connections, Wi-Fi enable, and all that. And on top of that, then we start using using the technology. And the technology has to be such that it has to be very simple. It has to be dummy proof. So idiot proof, and software for dummies, if there is something like that. So it has to be that way, because when we are treating patients as a physician or as a nurse, my concentration and my focus is on the patient. And the moment I see the patient and I need to document in the electronic medical records or any other IT system, it has to be very easy and it has to be fast. I cannot wait for 5 minutes even for the system to open so that I can start entering the patient details into the EMR. Or I cannot wait for printers not being connected, or something else is not happening as per the requirement. So, especially in India, where we deal with large volume of patients, fast and accuracy at the same time, efficiency is very very important. And now with earlier we started with hospital billing system, then we started with EMR system, and now we have gone into data analytics, and a lot of things are happening with the data that we acquire from managing various patients. So there are a lot of softwares that have come into place, IoT enabled devices, so on and so forth. So the interoperability between these devices is also very important. If you ask a doctor to log in one system for billing, one system for documentation, and one system to manage the telehealth, it's not going to work. So we need to bring in systems which are interoperable, which can be easily connected across the spectrum of patient care, from patient registration to acute care to home care. Because as we have learned from pandemic, home care is such an important aspect which was very very neglected earlier, which we cannot neglect now. As you know, many mild symptoms, moderate symptoms of COVID, many of them were managed at home through tele consultation, and through video calling, and so on and so forth. So it is very important that the whatever product that we look at technological perspective covers this whole spectrum of patient care. So these are some of the points that I think is very important when we are looking at the role of in IT infrastructure in the design aspects, keeping in mind what we have done in the past and what we experienced in the last 2 years, and how we should take it forward in the coming years. Thank you.
Thank you, Dr. Chandrika. That was quite insightful. And technology in healthcare is something people can continue to discuss and deliberate up for hours, because that is technically going to be going to be the next, or is rather the next phase of healthcare. I will now move on to a very strategic question to Mr. Dibyajyoti Dattaroy from RJP Architects. And the reason why I say strategic is because the overall concept of designing hospitals now is a totally different ballgame. And he, coming from an architecture background, I'm sure would have faced these stumbling stones of developing infectious diseases wards suddenly, which sprang up in hospitals before, during the pandemic, or maybe having flu clinics in the hospitals, having emergency isolation wards. So these are things which were not the norm of ground zero till the time we hit a zone where we realize that it just doesn't function without that. So for example, screening areas, etc., it's a total new dimension to zoning, the concept of zoning in hospitals. And with that, I think a lot of us have unlearned and relearned a lot of things, and are continuing to learn a lot of new things that are required. So Mr. Dattaroy, why don't I put the ball in your court with a very strategic question, which means volumes to all of us healthcare workers. So, is the pandemic really bringing in a renaissance in design with respect to hospital space? And what's your view on the trends in this space? Are we, over engineering the entire concept, or are we kind of not able to see the end of, the end light to where we want to reach? Is the goal a little hazy? Just wanted to hear from you on what do you think is the renaissance that we are seeing in design as part of the pandemic strategies.
Okay. Thank you, and thank you, Elets, for letting me sit in this with this esteemed panelist. Uh, to answer your question, see, I see whatever I've learned from COVID. there are two things which needs to be taken care of. One is the new design trends, and when I say new design trends, I'm talking about design trends, revival of old design trends, as well as incorporating new design trends. And the second is adaptability, that is kind of flexibility into our healthcare system. Now, if we talk about the new design trends, as you rightly pointed out, that we need to ramp up our emergency areas. Hmm. There's, that's the most important point, but what we have learned from the pandemic. Uh, but before the emergency area, we need a kind of a pre-triage area for the patients to be screened before even they enter the hospital. Hmm. I'm talking in perspective of pandemic situations. Now, if we have a pre-triage area, which we have seen in many hospitals, they have tents outside the hospitals. They have buses standing outside the not only in India but abroad also. So, if you have a pre-triage area, maybe we can incorporate self-check-in system where it's less contact. So, after that, the emergency area, the way we used to design emergency areas, that needs to be redeveloped. We need a bigger emergency area. We need better observations and screening, because a lot of smaller hospitals, they use emergency as throughput area where you just go in and then without any observation you go out. So instead of doing that, we need to scale up those areas and to have better screening, better observation in the emergency area for better segregation. Second point that I think is what we need to do is, in many cases, we have seen that the hospitals have suffered because other acute patients could not go to the hospital or could not take take advantage of the healthcare facilities because of the COVID situation. Like, I know of one person in my locality, a pregnant woman. She couldn't go to the obs and gynae place in hospitals because the hospitals were filled with COVID patients. Now, in our design, uh, earlier we used to have different blocks. I'm not suggesting that we are going to have different blocks, but because of shortage of real estate. But even within the consolidated hospital, if we can somehow segregate the acute inpatient areas from the ambulatory care areas, so you can have the hospital running their regular facilities simultaneously when a pandemic situation kicks in. Yeah, I know then we need all the beds, whatever beds are available, and for such we need to take care of more beds, but I'll come to that later. That is second point. Third point is that uh, many hospitals nowadays, because of shortage of real estate, we are doing away with liquid oxygen tanks area. Hmm. Now, we all know that a COVID patient needed 3 to 5 times more oxygen than an ICU patient. So there's a huge load on oxygen tanks. And a liquid oxygen tank usually gives out around 800 times more than gaseous oxygen. So we have to earmark areas for liquid oxygen tanks. I know that we have to actually segregate 9 meter by 16 meter of fenced areas where we have to put liquid oxygen. But in Delhi, as well as in other parts of the country, we have seen that the oxygen shortage has been acute. So I think we have to move away from this idea of using every square inch of the. We have to use the FAR, that is the floor area ratio that we get to build a hospital. But we usually eat up a lot of soft areas, soft landscape areas. We make them parking, we make them something, we use them for something else, for generators and stuff. But we have to earmark areas for liquid oxygen tanks. So this is an old trend which we used to have. So I think we are going to go back to that area. Fourth point is the use of natural light and ventilation in hospitals. I mean, there is a huge stress on that, and this is not only because of the patients, but for the staffs also, for the doctors also, because this pandemic, what has taught us is that the patients as well as the staff, they were under heavy pressure, and they were stressed. So it's kind of a stress buster. A hospital that we had designed in 2008 in Kolkata, and in that hospital, we had all the areas which were naturally ventilated with natural lights, and we had gardens areas like near the cardiac center, cardiac ward. We had a garden which was a kind of a health garden. So those natural light we have seen and even the doctors, you also will agree that they actually enhance the healing environment much more. And incidentally, in 2007, there's a personal thing. In 2007, I had to undergo angiography, and after it was all clear. But after angiography, when I came to my senses after my drug-induced stupor, I asked the nurse what was the time, and she said 4 o'clock, and I had no idea whether it was 4 in the afternoon or 4 in the night. So that's the premise that we had when we started designing hospitals, that every area, even the ICUs, would have natural light, and each of our buildings have natural light. Then another thing that is usually common in hospitals, where you have OPD chambers of doctors along the periphery, with a waiting lounge right in the middle, where the waiting lounge doesn't get any light. So we have to rethink that, so that those areas also get proper natural light and ventilation. So that's the fourth point that I have. Then I think we need to look into more durable and easily maintainable materials for hospitals, because the after the pandemic, the the chemicals that were used, those were in some cases, they were the materials that we use in hospitals, they were not conducive to take care of those chemicals. So I think the better durable and easily maintainable materials need to be looked into. That's something which I think we are going to do, and I'm sure other architects also will be taking care of. Uh, then we come to a situation where we are talking about surge. Suddenly, the patient number of patients actually increased because of pandemic. In that scenario, there are two sides to it. One is that if we can ramp up our hospital facilities to incorporate more ICU patients. Like in a hospital, we had to convert a, a dialysis center into an ICU. Similarly, if we can have pre-operation surgical surge prep areas, if that can be ramped up, for that services need to be incorporated, so that in a pandemic situation we can take care of those areas and convert them into more isolated areas. Uh, Talking of trends, another old trend we had was a double corridor. Like Mr. Manchanda just said, that single usage, single unidirectional corridors. So there is a concept of double corridors with doubly loaded rooms, so that the segregation of infected patients and the normal patients and the staff are much more applicable in that case if we have double corridors. So we have to think about those also. This was a trend which was there in a lot of government hospitals. We still have doubly loaded corridors for OTs mainly to segregate the sterile areas properly. But I think for normal wards also, that can be looked into, and maybe with a courtyard system we can have double loaded corridor with natural ventilations. Uh, this is one side how we can ramp up the hospital to cater to surge. The other thing that what came to our mind is whether we can convert any existing building into a healthcare facility in order to take care of the surge. Like we talked about the airports, and I think Dr. Chandrika talked about airport. No, so I think Mr. Manchanda talked about airports. Uh, and hotels being converted. Uh, I think if we can somehow build multi-level car parkings into convert them into healthcare facilities, uh, that would be much better, because when we design hospitals, especially hospitals which are multi-storied, we usually take care of the parking grid. So the parking grid, multi-level car parking with minimal services incorporated, uh, I know that will not be used so much, but in terms of pandemic, that can be easily converted into a hospital. Lastly, I think our primary care facilities in the rural areas, as well as tertiary care facilities, have to be ramped up. Otherwise, there will be a constant surge of migrants from the villages, from the rural areas into cities, increasing the load on the hospitals in the cities. So I think the primary and tertiary care facilities need to be revamped, need to be looked into, and more facilities should be provided. Thank you.
Thanks a lot. I think we've spoken about a lot of different dimensions of design trends, but one area which is probably an area that we most commonly miss out on, or rather overlook or underplay, is the concept of marrying processes to the infrastructure. So what I in principle mean is that we all know that there is a green channel that is required in hospitals these days. But how many of us plan an express check-in channel in a hospital? Not many. Many of us try to retrofit it, but when we are fundamentally planning a hospital or a healthcare organization, these things get overlooked. And the concept of taking the hospital closer to the patient becomes even more precious, and it's more symbolic than brick and mortar. It is basically the concept of not just bringing the hospital close to the patient physically, but also bringing the hospital close to the patient in principle, in process. So with that, I get a very interesting example in my mind. And since I hail from Delhi, there is a very popular concept of the British era in Delhi NCR, the Delhi National Capital Region, which is the Cobra effect. So what used to happen back in the British times are that Delhi used to be majorly surrounded by a forest. The walled city used to be surrounded by a forest, and these forests had a lot of cobras in them. So a process was set in by the British government after they moved their capital to Delhi, and they said that whoever brings us a cobra head will get a gold coin. They used to call it an asharfi. It's a gold coin. So they thought that it's a process which will reduce the number of cobras and make that area safer for development and travel, etc. Over a period of time, the Britishers realized that the number of cobra heads coming to them kept on increasing on a regular basis. So they got confused. They said that, initially we would say get an X number of Cobra heads, and we would be very happy that, X Cobras are now lesser into the system. But over a period of time, they started getting 2X Cobra heads, and then 5X, and then 10X Cobra heads. So some intelligent Britisher went into the system to identify what the problem was. And he realized that the Indians were actually rearing cobras in their homes, cutting their heads off, and taking them to the government to get the gold coins. So such is process excellence, that you may come up with a process, you may try to retrofit a process, you may feel that the process works absolutely well because on paper and theory it is the best thing you could have done. But in principle, whether the process marries to the infrastructure, marries to the people, marries itself to the general ecosystem is extremely important. And that is where comes the role of quality. These days quality is not just an accreditation team. There was a time in healthcare, and Dr. Chandrika would agree with me, she's been part of the medical services for long enough, wherein the quality team was looked at a team which would come into play at the time of an NABH inspection or a JCI inspection. After the inspection gets cleared, they get their bonuses, and then nobody cares about them. So that is gone are those days. Now quality is such a fundamental process in hospitals that quality teams eventually become teams which open up a lot of channels for revenue, EBITDA, profitability, etc. And that's how the the specialty or that discipline has evolved over these last few years. So I'm going to come to Namit on this, but before that, I also want to mention something which is very close to my heart and is extremely important in today's time, which is technically marketing communication. So many a times what happens is that we may have a lot of good processes, a lot of good infrastructure initiatives, a lot of good, I would say, innovative out of the box ideas that we have executed in our hospitals. But most of the times what healthcare in principle fails at is to effectively communicate that to the patient or the person on the other side of the table. And that is when the merit of a fantastic idea gets diluted. And unfortunately, that's something which we see very commonly in the healthcare space. So I'm going to come back to Namit Soni, who's the director and CEO of Soni Hospitals, on these two very, very fundamental aspects. And I'd request him to take them up separately, and then eventually, kind of just enlighten the audience on how quality and marketing communication go hand in hand. Because now quality is no longer a specialty which was focused at one particular actionable, and marketing communication is not putting up boards in the hospital and elsewhere. It's much more than that. Namit, over to you, please.
Hi. First of all, I'd like to thank the esteemed panel and Elets for giving me this opportunity to be being part of such an informative panel. Thanks, Dr. Saurabh, for amazingly moderating the session and getting different views of different specialists, especially from different domains. And I think to start off with the fact that you mentioned, there are other industries, and I kind of resonate with the idea that when you take a best practice from another industry and get it into healthcare or say into another industry, that's actual true innovation. And that's the way forward when you look at survival, and not looking at survival as just letting above you, taking yourself above your competition. So before I get into answering both those things, which somehow I was also thinking of putting into a thing, I would like to just share with everybody, in fact my panelists and my audience here, that just want to set the base right, that these some of the complexities that we're talking of is in this day and age in 2021, which we say is the new normal, is that a lot of things were already in progress, and the complexity was already in progress. It's just that the pandemic accelerated them, uh, starting with the fact that there are new patient journeys in place with involvement of more care being given at home. Then complexity of the aging population, the fact that comorbidities are increasing, the lifestyles are going down, the way we look at how the diseases are coming in younger patients is increasing. So that is happening. Third is how more patient data is being collected and being made available to the specialists, whether it is the doctors, the hospitals, across the board. And the fourth is how we are moving very clearly towards evidence informed care. So all these three, four points have been extremely accelerated with the pandemic, and that has brought about a certain change in our design thinking for the hospital, our design thinking for our processes. And that's where I want to summarize what what architects Manchanda ji and Roy Saab said, that we're talking here of more resilient hospitals, hospitals that are there, where we are looking at self-cleaning materials, where we are looking at zero infection zones, where we are looking at anti-infective surfaces. So a more resilient hospitals is what we are looking at in terms of, and that is where, Dr. Saurabh, I want to add in your point of marketing communication, because with all those changes coming in, the communication, or as I say, not marketing communication, but patient education is becoming paramount importance, whether they need to, when they need to understand how their care is being given. And in some part, it is already happening because of patient consumerization. Patients are now looking at hospitals and our service like other areas, like probably like a McDonald's burger for that matter. They want to see how the process is happening. They want to understand how their care is being given, and they want to track every minute of it. They don't want to be seeing that if a patient enters a hospital, they don't want to wait 2 hours for the treatment to start. They want to see where the time is being devoted and why can't it start immediately. So they want to see transparency into our processes. They want to look at how we want, how they are getting the service delivered to them, and that is bringing a lot of change in the way we give our healthcare, the way we design our infrastructure, the way we define how. And coming back to the accreditation and NABH, we start off in our accreditation with scope and out of scope services, and that has become a very important factor, and you can say a very important element for hospitals today, because the way forward has become is co-optation, where you take up certain things and you partner with people and deliver services to your patients. So the idea here is that you're looking at patient journey as a whole, and you're ensuring that the patient gets that complete care, even though part of it is being given by another partner coming into from. uh, just to give you an example, during COVID we had the RT-PCR tests. So RT-PCR was a test which was not easily could not be started at every hospital. Slowly and slowly the centers increased, but at the start all hospitals required those. So to fact that to get that smoothly into the system was one of our challenges, and that I think most hospitals managed it well, and that was exact example of co-optation in our case. So what I want to stress on here is that our systems need to become more agile and more flexible. We saw all of this in our COVID, my co-panelists have mentioned how surge of patients have to be managed. So our system need to be flexible. I'm sure at HCG and at Max Healthcare at Dr. Saurabh setup, we have seen a lot of change from COVID areas to non-COVID areas and then back to COVID areas, and a lot of flexibility in utilization of that space has taken place. So that has become very important, and that is where the role of how you guide your patient, how you inform your patients, and how you separate your patients has become very important. And that is where these soft skills of communication, of say you can say consents, of informing the patient about the care that has to be given has become very important. The second is personalization of care. One biggest change that we are seeing today is personalization of care. That is virtual care coming in, technology based care coming in, as well as the attention of caregivers coming into each patient in terms of how that care is to be delivered to the patient. Those things are coming in. So that all these things combined are making a big impact on the way the hospitals and the space and processes are designed. Last thing I would like to share for everybody would be on the fact that it's not just the physical health that we are looking at right now. The mental health aspect we've time and again seen in the background, and now with COVID coming in, the fact that mental health of a patient, and I think indirectly it was touched by both by Manchanda Saab and Roy Saab on the importance of healthy space, a heart garden around the space. That how important is a mental health of a patient when he's going through treatment. We have seen time and again how patients who feel that they're recovering, and if they're given in a positive environment, their recovery improve, the rate improves. So what we feel is that one thing important which everybody needs to look at when they're designing hospitals and designing processes is both not just the physical aspect but the mental health aspect of the patient, and how the communication goes with that patient, and how that repeated communication goes. Just to share with you on one example of that. So information is key here, and I keep coming back to the thought you're mentioning on marketing communication is that if a patient is well informed of the risks, well informed of what he's going through, what are the complications that are there, what he's expected, that really relieves him of the uncertainties that are going to come beyond the door, beyond probably the OT, the ICU, or whatever procedure or health he's going to go through. So if we have the right processes with the right communication and a healthy environment in place, a well lit open space in it can make a lot of impact in patient care and recoveries. And that's the thought I want to leave everybody with on how flexibility has become the motto of how we want to design our healthcare systems. Over to Dr. Lal on the same.
Thank you, Namit. That was quite enlightening. Also, we've I think touched on almost all aspects of design, but as a doctor turned management professional, I think design is something which has been very very close to my heart, and I've kind of ensured that there was no stone unturned ever where a design could improve. So I strongly believe there is no perfect design, but then as healthcare professionals, the expectation of the patient is that we are as close to perfection as it may be, and that makes it extremely important that we understand how important it is to set the expectations of the patient. So a very common a common practice of hospitals across the country on experience of the patient focuses majorly at the medical aspects. But then I keep giving this example to my teams that if we look at the general life cycle of a patient in the hospital, we can divide it into three parts. One is the first part, which is the pre-surgery experience. The second is the actual surgical experience. This is the core experience which the patient is coming to the hospital for. So if I need a cardiac surgery, I will choose the best hospital, I will choose the best doctor, and I will go in for the surgery. But the second aspect is being the core also has a third aspect, which is the post surgery experience. Now I always keep telling my teams that when a patient comes to a hospital, he enters the hospital, first struggles for a parking slot, gets a parking slot, goes on to the front office, the IT systems are down. I'm giving a generic example. That causes a lot of delay to his admission. Then he moves into a room, the call bell not working, infrastructure issues with the washrooms, etc., etc. So this comes into the pre-surgical phase of any patient. Now comes the second phase, which is the surgical phase, and this is the core phase for which the patient has come to the hospital. Now, unfortunately or fortunately, when the patient moves into the second phase, which apparently is the main reason why a patient has come to the hospital, we doctors anesthetize the patient and the patient goes to sleep. The family is outside, they don't know what is happening inside till the time the doctor comes out and tells them. If the patient survives, obviously the surgery went well. But technically, this phase, which was the main phase of why a patient comes to a hospital, is when the patient is actually asleep. There is a term in the OT used as timeout. Timeout means when the patient walks off. So, and then the patient goes into the post-surgical phase, which is the discharge process, which is whether the discharge desk is on the same floor or the patient has to run around across the hospital, whether there is an express checkout process for cash and insurance patients, whether there is a hand-holding desk or a may I help you desk on every floor. So, when we look at the end-to-end patient experience, it is the overall experience, not necessarily whether the surgeon did a fantastic job at the surgery or not. And that is what we as leaders in the healthcare space need to understand, that patient expectation setting is extremely important. Another example that comes to my mind is that there was a patient who came to our hospital for a very major complex high risk cardiac surgery, neurosurgery. The patient was refused by all major hospitals of the city and he landed up to Max. We operated him and fortunately we could save the patient's life. Now we went to meet this patient post surgery, and this was a patient which was actually a published case and we were very proud of saving the life of such a high risk surgery patient. And the first thing the patient said is that, sir, आपके doctors बहुत अच्छे हैं, hospital is fantastic, but एक problem है. आपका जो खाना कस्टर्ड आता है ना सर, उसकी जो ट्रॉली है उसमें बहुत आवाज आती है. I can't sleep because the whole night the F&B trolleys are doing the rounds of the corridor. Now, this is a patient who probably would not have been alive to have that custard. But the expectation was that surgery to kar hi lenge. They are doctors, they know their job, it's a good hospital. So surgery to inke bas ki hai, kar lenge, but custard bhi serve karna nahi aata dhang se. So, that is the level of expectation of patients today. And this reiterates what I believe that, there may be no perfect design, but healthcare has very limited scope of making errors. It may be clinical, it may be non-clinical. What the patient understands is non-clinical. Patient doesn't understand clinical stuff. And hence, towards the culmination, I will not pull this too far, but towards the culmination, I personally believe that there is no crash course to design. But the fact is, nor will any such session make us design champions overnight. What sessions like this, what discussions like this will do is, it will plant that seed of inception for innovation and out of the box thinking, where somebody somewhere somehow will suddenly realize that what I'm doing for the last 10 years, 15 years is not the way to do it right. We were sitting in a discussion in our hospital once, and somebody from our leadership team came up and said that, what do you do in an admission process? We said, sir, the patient comes in, he fills a form, then my guy takes the form, replicates it to the computer, the IT system's not working well, so it takes time, etc., etc. And he suddenly snapped back and said that why are you not learning from the airlines industry? There is something called as a web check-in for airlines. And we were like, exactly, why didn't we even think of it? So what the web check-in does is it allows the passenger to fill out all these details while the person is sitting in the drawing room of his house. So we as a hospital have started working towards figuring out if we can have the patient sit in his house. See, the admission process, the bed management process will take 2 to 3 hours, 4 hours, 5 hours, whatever it takes. But the option there is whether the patient sits in a cafeteria in the hospital or the comfort of his or her home. And that is where we realize that why can't we have a system where the patient fills in his details at home and sends it to us, comes to the hospital only when we give him a green signal that your bed is ready, please come, take your face sheet and go into your room. So that is the innovation and out of the box process that is kind of required today. And I think all of us are working very aggressively towards it. There is this concept of no touch, no paper mechanism that has come in suddenly in our lives, which we have grown up alienated to because we never believed. I mean, till the time, I still remember, till the time we didn't touch and feel things, we would not believe it is true. But today we are looking at processes where there is no or minimal transfer of materials, papers, etc., etc. And hence design becomes more and more important, and design thinking comes into play when we are able to kind of bring in things that never existed in this industry. And I think that is where the healthcare industry is heading. And I think this is the next step. This is the new path that healthcare professionals like us need to take and ensure that our hospitals become smarter and not just hardworking places of healthcare. Thank you so much. That's all from me. Thank you to all the speakers, Dr. Chandrika, Shamit, Mr. Roy, and Namit. I think that was a fantastic discussion. I'm sure the speakers must have, I'm sure the audience must have gathered some small little points. The 80-20 rule exists here, where people will probably forget 80%, but if they remember 20% of what we've done here, I think we are home. So thank you so much. I will pass this on to Mrinmoy, and happy to be on this forum.
Thank you,
Thank
Dr.
you.
Lal. Thank you, Dr. Lal, for moderating this panel discussion. And that was a very interesting. Lot of live examples, experiences that came out from eminent panelists. Uh, Thank you all. I would now like to request my team to bring up these certificates. Would like to present it as a token of our appreciation to you. Thank you, Mr. Shamit Manchanda, for participating in this panel discussion. Thank you, Mr. Debojyoti Dr. Roy, for participating in this panel discussion. Thank you so much, Dr. Chandrika Kambam, for participating in this panel discussion. Thank you, Mr. Namit Soni, for being here. Thank you, Dr. Saurabh Lal, for participating here. Thank you, ladies and gentlemen. Thank you for investing your time in this platform and educating our audience. Thank you all, and stay
Thank
safe.
you.
Our
Thank
next
you.
session
Thank
begins
you.
in 15 minutes. Thank you. Bye bye.
Thank
Bye.
you. Thanks a lot.
Thank you.